Ultimately, what we're all looking for in our healthcare experiences is to be heard, to be respected, to be treated with dignity, to have a voice, and to have our caregivers involved as part of our healthcare team as well. So certainly not too long ago, I would say person-centered care, which is the terminology we use at Planetree, person-centered care versus patient-centered care. It was seen as sort of a nice value add to quality and safety efforts. But now we know definitively, and I'll share just a little bit of that evidence with you, is that it isn't just something that's nice to have. That person-centered care and those partnerships at the heart of person-centered care are truly integral to quality and safety. So it's not just a driver of loyalty and satisfaction, which are certainly important from the perspective of healthcare organizations, but what we're talking about are relationships and partnerships that ultimately create better healthcare outcomes for patients and for family caregivers. And that's because, you know, this is different than patient experience. So you may hear talk of patient experience efforts. This is more than hospitality. This is more than a piano in the lobby or a Starbucks in the lobby or room service or having volunteers coming with cookies or having pet therapy, all of which are great. I don't mean to begrudge any of those things, but I would say those are sort of the signature moments on top of really the meat of what we're talking about in terms of person-centered care, which emphasizes caring, it emphasizes inclusion, and very importantly, it emphasizes personhood. So who is this individual that we're caring for? What strengths do they have to bear? What are their challenges? What are their realities? What are the experiences they've had? What is their background? And how does all of that influence their expectations of healthcare, the way that they interact with their healthcare team, how they're going to be able to manage their care on their own? So because of that, that's why I say we can't talk about person-centered care without getting personal, because you cannot provide person-centered care and continue to keep patients and their family caregivers at arm's length and sort of treat them as spectators or subjects of their own care. They are our partners, and that cannot be just in word, right? This needs to be in word and deed. We need to put actions, structures, processes, practices behind that commitment of partnering with patients and families. So what they knew then, again, they knew intuitively when we founded Planetree, which is that quality comes not only from providing the right care and at the right time in the right place, but that care is delivered with compassion. So in a way that addresses physical and medical needs, but also human needs for connection, support, and understanding. And it's also delivered in partnership with patients and families. So shifting that dynamic of delivering care for or to patients to delivering care with them. In a person-centered healthcare organization, all three of these, quality, compassion, and partnership, really do coexist in equal measure. And certainly what has resulted, what has come to be as a result of the pandemic has created a lot of challenges when it comes to person-centered care. And to be very blunt, I think, I've seen a fair amount of regression. We've made such great progress, and there have been some really challenging circumstances that have caused a number of healthcare organizations and systems to take a few steps backward. Now, this is being done with the best of intentions, but I think there are some really important things that have been overlooked, and that's where Planetree as a person-centered care advocacy organization has been saying, no, wait, we need to think about how can we preserve quality, compassion, and partnership in a way that keeps everyone safe, but also doesn't undermine those partnerships that we've been working so hard to cultivate. And it's because things like these hallmark person-centered care practices, which are hallmark Planetree practices, like sharing the medical record, partnering with family caregivers as members of the healthcare team, shared decision-making, asking what matters most to you and building that into the care plan. All of that strengthens partnerships and enhances communication between patients and their caregivers, which supports quality and safety efforts. We need to acknowledge that a global pandemic doesn't negate that evidence I just shared with you. All of that evidence remains very, very valid. However, the landscape has changed. So we do need to be intentional in thinking through, how do we balance safety and risk with compassion and partnership? So asking ourselves those questions, like how can we minimize transmission and limit risk while building assurance that patients are safe in our care? And how can we do that while balancing those human needs we talked about, particularly when people are at their most vulnerable? And doing that while guarding against, I think, this inclination to kind of regress back to a paternalistic, we know best approach. And instead continue to engage patients and family members as our partners, even when we are sort of dealing with the most challenging situations. So if we can preserve those partnerships while we're in a crisis mode, that is a person-centered culture. If we are only partnering with patients and family members when things are sort of business as usual, we haven't gotten to a truly person-centered culture. But there is a lot of research around the importance of families' presence and participation. We know that the presence of a care partner helps patients to better recall information that's shared with them during an appointment or during a visit. It reduces the likelihood of an avoidable readmission. It results in better self-management and improved outcomes. So lots and lots of evidence that supports the importance of engaging family caregivers. And here's some of that lived experience evidence that I think is really important to just demonstrate. We've got the scientific evidence, and then this is the experiences of real people. And these are people we've interviewed at Planetree about sort of what it means when their loved one is involved as part of a care team, but also conversely, how it feels if they're not. So the final quote at the bottom, I had a double mastectomy, and it would have been nice to know that my daughters could have learned the dressing changes while they were here in the hospital and before I went home. Instead, we went home and it was trial and error. In many cases, as you all know, family caregivers are their loved one's voice, their advocate, the person who is managing their care. And to not have them be physically present to interact with the care team and to observe and interact with their loved one can be really detrimental to their loved one's health and wellness. These 8 guidelines that we developed, the person-centered guidelines for preserving family presence. It's a document that's available for anybody to download, and we invite you to do that and to share it and to bring it to meetings, to bring it to healthcare organizations when you go. And what these 8 guidelines do is really lay out a compassionate approach to visitation or family presence that benefits the families, that balances the family's physical presence and the need to minimize the risk, obviously, of transmission of COVID-19. So we are hoping that these guidelines that we've developed are high level enough and general enough that it's not specific to COVID-19. The intent here is the next time, and probably, unfortunately, there will be another crisis at some point in time. Hopefully it will not be a global pandemic, but there will be future states that start to challenge and undermine person-centered approaches to care. But our hope is that by having we didn't have a playbook before. Now we're starting to put together a playbook. How do you respond in a person-centered way to these types of crises? And that's what these guidelines are meant to do. An important distinction that we introduce early on in the guidelines is the distinction between casual visitation and a care partner. And I've talked about sort of what a care partner is and how we define a care partner as an essential family caregiver. And I think at times of greatest risk, it absolutely makes sense to differentiate between what general visitation may look like versus a patient being able to access his or her care partner in person. So in many cases, virtual visitation isn't going to, because I know there's been so much talk of virtual visitation as if that's the solution, but in so many cases, virtual visitation isn't going to suffice to really support care partners' involvement. But for casual visitation, that may very well be appropriate. But I think they're two separate conversations. And that when we are looking, if we're saying a care partner is a member of the care team, then they're treated as a member of the care team. They're getting the PPE they need, just as a member of the care team would get. And the policies and sort of how they're screened, how they are protected, and how they are supported to continue coming into the facility, that's as a member of the care team. So the first guideline is to assess whether there's a need for restrictions to family based on current factual evidence, and to continually reassess and adjust policies as conditions evolve. This may seem like a no-brainer, but it was really, really important to start here, because as you all know, this has been a rapidly evolving, constantly changing situation. And given the importance of family caregivers and the role that they play for patients, for patient care, it's really important that if we are going to limit access to family caregivers, to care partners, that those limitations are based on the most current information we have about risk. And that policies that were in place in March of this year, that they haven't just remained as is, however many months later, but that as things have changed within the community, and that's why we're also looking at this at a community by community basis, not even at a statewide basis, that based on your own community and the state of spread, the availability of PPE and tests and ability to screen and staffing, that all of those things are taken into consideration when any changes are made to visiting policies, whether restrictions are eased up on or whether they're having to be reintroduced. And part of that assessment of risk, and I would say probably the most important assessment of risk, is this question. Do restrictions to families' presence and participation actually create a safety, clinical, or emotional risk to the patient that outweighs the risk of COVID-19? And in some cases, that the answer to that is that it is actually more risky not to include family caregivers. And so we need to find ways to support their presence in a safe and responsible way. The second, of course, we need to be minimizing risk. That's essential to being able to ease restrictions around family caregivers' presence, around care partners' presence. We have to find ways to follow appropriate infection control guidelines so that we can minimize the risk of transmission when people physically are coming into the building. So there are certain steps that you can take, and they are based on these evidence-based infection control protocols, like screening care partners on entry, providing PPE. In many cases, a cloth mask from home suffices. Maybe a designating specific pathways to and from areas where patients being treated for COVID are. So you can sort of create these separate pathways through the building. Having care partners practice physical distancing or even sheltering in place. In some children's hospitals, they have parents sheltering in place with their loved ones, and so that would be a possibility. Outdoor visitation when possible in those areas where that's still possible as the seasons start to change. These are all ways that you can minimize the risk of physical presence and support families' abilities to still be there with their loved ones. The third guideline focuses on communication. And I would say when it comes to communicating changes in policy around visitation, over communication is key. The last thing you want is for a family to show up at the facility and not be aware that what your restrictions are or what the expectations of them are. I think it's really important to meet people where they're at. So not only are you over communicating, you're thinking, where can I make sure that these messages will reach people? So on your public website, on social media, doing robocalls, doing email, making sure it's part of, if somebody has a planned admission, that phone call and the pre-admission includes a discussion of of the policies around visitation. And then we look at compassionate exceptions. This is a pretty standard piece of the visiting policies that I've seen pretty much from the very beginning. I think a good example, initially all visitation at hospitals and long-term care communities was suspended. And then 9 or 10 days in, the State Department of Health introduced some compassionate exceptions around end of life, pediatrics, mothers who were in labor and delivery. And also then there was this additional language around patients for whom a support person has been determined to be essential to the care of the patient, which included patients with intellectual or developmental disabilities and patients with cognitive impairments, including dementia. Now, I would suggest when it comes to these compassionate exceptions, a couple things. One, really important to engage patients and family members in defining and determining who is an essential family caregiver. And secondly, putting in place processes at the healthcare system level for making sure that those determinations for exceptions are being made on a fair and equitable basis, so that there's some standardized approach or rubric or set of criteria that those decision makers are using, so that it's not just dependent on who happens to be the decision maker that particular day. So I've been seeing more sort of compassionate exceptions committees that meet as needed. They're on call, they meet as needed, because it's important that these decisions be made on a timely basis as well. So what we recommend is that organizations are making it public, sort of publicly promoting or publicizing who you would contact if you wanted to request a compassionate exception. So this shouldn't just be information available to those who are in the know, but that anybody who would like to be able to say, this is why I'm an essential family caregiver, has access to that contact information of whoever that institutional decision maker is. Number 5 looks at how to support meaningful connections to minimize isolation in cases where family is unable to be physically present using virtual or other means. It will be, when you do those risk benefit assessments, that for some patients or family members, it isn't possible for the care partner to be there physically. So how can we support their involvement? One thing that we would say is I think it's really important that we not over rely on the virtual visitation and those sort of technological means of connecting, because for some individuals we know it actually can create more problems than it solves. It can be really challenging for communication. It can create confusion and anxiety. And so we've been also worked with organizations that take a more sort of high touch solution, which is repurposing staff to serve as connectors. So it might be medical students or staff from other areas who are actually connecting with family members. So maybe after rounds, they're calling up a family member to make sure that that family member is getting real-time information following the discussion with the rest of the care team. We advocate for a shared decision-making approach with family caregivers, so saying, these are your rights, these are your responsibilities, these are the risks, these are the benefits, these are the options for how you can engage as a family caregiver, virtual and in person. And together, based on this information, let's determine what is going to be the most responsible way for you to engage. And then, because care partners are members of the care team, they are our partners in quality and safety, it is absolutely appropriate that care partners should share in the responsibility for abiding by established safety protocols. So part of this agreement is the understanding you need to use your PPE. You need to practice appropriate hand hygiene. If there's an agreement about limiting contacts outside of the hospital or the healthcare center, or limiting their roaming around the hospital or going to other settings, that they're abiding to those agreements. And then finally, really quickly, recognizing how important care partners are to those transitions of care, which I mentioned earlier, looking at how can we enhance discharge education and post-discharge follow-up, recognizing that family members may not have been able to be present during a hospitalization, or their presence has been limited during key interactions. So the follow-up care, the follow-up calls that are being provided, perhaps enhanced home care, looking at discharge instructions and saying, how are we providing this in a way that people can understand? Are there videos? Are there other ways that we can convey this information, because we don't have the ability, if they haven't been there in person to necessarily ask questions and observe us in action, we need to fill that gap because we know it's so important. So those are the 8 guidelines. They are not in any way meant to supersede any regional mandates that exist, but we have been sharing them not only at the health system level, but also at the state level, trying to influence state departments of health and other regulatory bodies and authorities. We've seen some success there. Of course, this is a constantly evolving situation, but one thing that we have really encouraged, so we tend to work mostly with healthcare organizations, and many of the conversations I've had have been around how can we change the conversation around visitation and family presence. And one way to do that would be to say, you know, in these meetings where these decisions are being made, ask yourselves, if this was my loved one, if this was my most important person who was in that nursing home or who was in that hospital bed, would our visitation policies as they currently stand meet my needs as a family caregiver?